with 1000 qubits. In quantum communication, target has been set to develop secure communication, both satellite and fiber-based networks. In sensing and metrology, target has been set to develop magnetometers, gravimeters, and atomic clocks. In materials and in 3 phases. In phase 1, prototype development. In phase 2, product development and deployment. In phase 3, business development and economic growth. Department of Science and Technology has established 4 thematic hubs. These key hubs will work with the technical groups and drive the innovation. These key hubs are Section 8 companies. These key hubs are responsible for technology development, capacity building, supporting startup, industry partnership, and international collaboration. I would like to give a glance about the thematic hubs and technical groups. Quantum Computing Hub, established at IISc Bengaluru, coordinating with the 4 technical groups. Communication Hub, established at IIT Madras, in association with CDAR, coordinating with the 5 technical groups. And Sensing and Metrology Hub, established at IIT Bombay, coordinating with the 2 technical groups. And Materials and Devices Hub, established at IIT Delhi, coordinating with the 3 technical groups, and launched on 30th September 2024. These T hubs brought in about 150 researchers from 43 institutions across India. It is a pan-India program. DST would like to facilitate the economic growth of startup ecosystem and active part of the technology delivery. T hubs will create the national facilities open to the startup. T hubs will provide the technology and business mentoring and equity support to the startups. National Quantum Mission has developed exclusive guidelines for the supporting the startups, since it is in the nascent stage and require huge investment, and supported 8 startups in first phase, and launched on 26 November 2024. DST intends to actively engage the industry stakeholders to enable technology transition. Through T-Hubs, industry will have access to the national facilities, and T-Hubs and industry co-develop the technologies and eventually develop a revenue sharing model. As a part of NQM, Department of Science and Technology initiated Quantum Awareness Program among the students, researchers, industry professionals, and policymakers. Through this initiative, DST intends to build capacity and contribute to policy development. As a part of this program, NQM, in collaboration with the AICTE, developed curriculum on quantum technologies for BTech minor and MTech, and launched on 24 December 2024 and 28 August 2025 respectively. Efforts are underway, book writings, recording video lectures, and faculty development programs. And DST will support the technical institutions for setting up the laboratories in quantum technologies. In addition, rolling call for supporting startup in quantum technology is open. All startup can submit their applications in all 4 verticals. Thank you. Thank you very much.
Thank you, sir. Thank you very much. You are very well explained about the quantum technology cell and quantum computing algorithms of different domain, and about the different startup, and encouraging us to give the collaboration. And I also give you information that in our institute, the Sambalpur University Institute of Information Technology, already submitted its proposal to the quantum technology cell with 6 number of the other institutions are the member of institute, and our institute is the lead institute. And again, with 2 medical industry is also collaborated with us. There, one is startup and one is already medtech, that one is already established institutes. Thank you, sir. Thank you very much. And in future, we'll call you again. Thank you, sir. Now I request Sumande madam to present vote of thanks.
Good evening to esteemed guests, respected dignitaries, members and participants. I am Sumande, co-convener. I am honored to deliver the vote of thanks for today's event, that is Atal FDP, titled Advances in Deep Learning for Medical Imaging and Disease Diagnosis. I would like to express my sincere gratitude to our revered chief guest, Professor Deepak Kumar Sahu, Honorable Vice Chancellor, VSSUT, for accepting our invitation and giving us his valuable time and insights. I would like to thank our guest of honor, Dr. JVP Reddy, Head Quantum Technology Cell, DST, Government of India, for being with us today and sharing his research experiences. Really, we are thankful to you, sir. I would like to thank Dr. Prabhat Kumar Sahu, Dean Sri, SUIIT, for his coordination and support throughout the conduction of the program. And I would also like to give a thank to Dr. Sudarshan Jina, Director, SUIIT, for his continuous guidance and support for conducting this FDP. Uh, at last, I would really like to thank Dr. Praveer Kumar Sethi for taking the initiative for conducting such a FDP, which would be eye-opening and insight and knowledgeable for all the joinees and participants. At the end, I would like to thank all the dignitaries, participants, and the organizing committee for their contribution, and the participants for us will be here with us for the next 6 days for the FDP in advances in deep learning for medical imaging and disease diagnosis. To make this FDP a successful one, we would like the participants to be always joining the sessions in time. Thank you, all of you.
Thank you, madam. So, in this way, the inauguration session is wind up. Now, for the participants, the third session will be delivered by Dr. Amit Karat, the co-founder of Deep Tech Technology. Sir, please begin.
Thank you so much for inviting me today for this session. It's a pleasure to be here. So I'll directly jump into the presentation and start with the discussions. As I understand, primarily the focus of this program is around medical imaging, and I bring to you the most important and primary imaging, that is the chest X-ray. And things which are happening in this space, how deep learning is evolving and moving across this field is something that will be an area of interest for me to show. So the title of my topic is AI-enabled smart reporting for chest X-rays, how it is transforming radiology productivity and accuracy. As you all know, chest X-ray is one of the most common imaging modalities, which is globally available. In fact, the most highly penetrated imaging modality globally. Yet, when I say it is the most highly penetrated imaging modality in terms of is available across the population, not only in India but globally, the total access should not be more than 50% to 60%. The entire rest of the world still lacks access to this very basic imaging modality, which is a chest X-ray. On an average, on a yearly basis, at least 7 to 8 billion chest X-rays are done annually, while some estimates share that it could be between 3 to 4 billion. There is no accurate estimate. This is a global estimate, but you can see like approximately 50% of the world's population undergoes chest X-rays. When I say that some patients will receive chest X-rays once in every 2 hours, particularly if they are in the ICU. And of course, there are people who will not even get access to one X-ray during their lifetime. Now, when we have such a powerful imaging modality at hand, the challenge what we see globally is that you may do a chest X-ray, but you may still not have access to radiologists to report them. The technology still is very primitive in terms of most of the 50% of the chest X-rays still today could be the conventional variety where you use dark room to process the X-rays. Though they are getting phased out, and we are seeing more and more of X-rays which are being done are digital. But it's going to be a journey where all these conventional X-rays will be completely taken over by digital X-rays. The digital boom is moving at a very rapid pace because X-ray machines are getting miniaturized. X-ray machines are getting smaller and smaller in size. At the same time, technology is making it easy to digitize X-rays and transfer these X-rays over a distance. And as a result of this, experts who are sitting remotely can also report these X-rays. But the problem with experts who are reporting remotely is that they are also inundated with a huge amount of workload. Just to give you a statistic, X-rays constitute the lowest in terms of the things or a priority on the mind of a radiologist. The reason is because high demand imaging modalities like CT scan, MRI, and patients who are physically visiting the hospitals, particularly for doing ultrasound, color Doppler, take center stage. As a result, all these imaging modalities go down in the list of priority. Many times these are unreported and go to the physicians directly. In this particular journey, as a result, AI is making a big kind of an impact and is coming in a larger way into the workflow. And here I am showing you two options or two different ways in which it is coming into the workflow. It is basically coming into hospital and imaging center market, and it is coming into the public sector. And both of these are different use cases. The public sector basically looks at disease control, infection control. Advanced countries and advanced nations which have taken the public health infection kind of has been got under control. For example, as the previous speaker was also mentioning about tuberculosis, then what remains is cancer. And chest X-rays are important to detect not only tuberculosis, but also cancer. Also, it could be used for detecting certain kind of infections which are very common in certain geographies. For example, silicosis, where there is mining is happening. Silicotuberculosis, again, where mining happens. Then pneumonias, pediatric pneumonias, adult pneumonias. And in the most common adult pneumonia today, what we look at is, we think of, is the COVID wave that went a few years back. But then every time, every summers or somewhere around that time, you'll see a new virus attacking the chest. So chest therefore becomes a very important area of concern. And our idea today is, why not have this as the most critical area and work in finding some solutions in this space. So that's how we are looking at this. The important aspect when we look at a solution, whether it is a hospital workflow or in a government setup, the idea is that we need to have a solution which works on the edge. That means along with the device. The device has to be digital. And second important thing is this particular solution need not require internet connection. It can work on a basic system or a very basic hardware, just like a laptop. And it can interface with the X-ray machine. And as soon as the X-ray happens, within less than 30 seconds, it should be able to give at least some delineation or a marker as to what's wrong in that particular X-ray. So if you look at the chest X-ray itself, then we have this different things. One is we can use chest X-ray for, if it is a hospital setup, then for improving the clinical productivity, or we can use it for screening like the TB screening, and or it can be used for visa screening. Now these are different use cases, and different organizations require these different use cases. For example, visa screening will be required where a lot of immigration related health checkups are done. This is primarily in large government practices also, where workers move across boundaries, national boundaries. TB screening is also part of that, but primarily it is used by NGOs and governments in high TB burden areas. And then the entire Southeast Asia, including India, is a very high TB burden area, as we all know. And that's where TB screening becomes important. And clinical productivity is in hospitals where radiologists are inundated with work, and AI can at least remove some of their stress, some of their burnouts, and improve the productivity in reporting. So this entire suite is our chest X-ray suite, and it can connect with any hospital existing ecosystem like a PACS. And the system is US FDA approved. It is C approved as a Class 2B medical device covering both adult and pediatric chest. And it is WHO recommended as well. Very recently, we got WHO recommendation. So the chest X-ray AI is again, we received the US FDA CADI approval, which is a 510K approval, and it makes it one of the few organ-based solutions to help kind of look at the chest. And what we do is we separate these X-rays as soon as they happen. Let's say hospital has a big workload. Most of the government hospitals or private hospitals today, which are large, anywhere from 300 to 500 to 1,000 beds, will do between 200 to 300, 400 chest X-rays. The biggest challenge here is just separating those X-rays, which are normal, which are abnormal. If it is abnormal, then which are critical? Because if the list is 200 patient long, and then there are CT MR also happening, we do a 50 CT, maybe hospital is 40 to 50 MR. Ultrasounds also, multiple ultrasound machines are running, and at least 30 to 50 patients are done in a hospital, how do I just look at the critical X-rays first? And the AI should at least be able to tell me there's a fracture, there's a pneumothorax, there's something happening in the chest X-ray. And that's what exactly the system does. It separates the X-ray within 30 seconds into normal and abnormal. And in abnormal, it basically tells which is critical, which needs to be reported first. And above that, it also goes and generates draft for abnormal reports also. So that's the entire package, and that is how the productivity comes in. It is not a replacement to a radiologist. It's an assistant to the radiologist. And all the AI products which are coming in the workflow today, whether it is in any regulatory domain, very few products are today allowed. I will say it's like a rarity to have a solution which will say we said that it will be used autonomously. To some extent, the TB screening solution is one which could be potentially used to some level as autonomous. But apart from that, most of these tools are assistive tool to an expert radiologist. So coming to the way the system basically can be used for hospitals is a phased-wise approach. So again, there's a big barrier when it comes to using these systems in hospitals versus using these systems in a public health screening setup. Because the AI here is a complementary tool to the radiologist to improve the productivity. But at the same time, it is very important that radiologists as stakeholders need to get accustomed to this tool and be comfortable using it. Because at the end, when it comes to AI, there is always a little sense of like how confident they should be while using AI. So as a junior resident in a hospital or a doctor, the radiologist also needs to be over a period of time get comfortable that okay, the AI will do good here. Here it may or may not do well. Here it is likely to fail, and learn the nuances, just like how a student in a hospital, when comes for a residency, is in a very naive state, and over a period of time is likely to get more and more better as they work with the consultant. Something similar happens when we look at the AI as well. It is we basically talk about it like it's a solution which could be used as a resident or a virtual assistant and just like complement your workflow. So when we start with the hospital, we start with the least barrier, the low suspicion workflow, that is sending normals. The second is sending normals with the normal report. The phase 3 is sending only the abnormal output for abnormal studies. And the last is adding the editable draft report even for abnormal. So that's typically how a hospital workflow is. Coming to the regulatory side, the regulatory process around all these solutions is a very long journey. And for us, if you look at it, the solutions are divided as CAD-E and CAD-T products. A typical CAD-T product can get approval from the US FDA within 6 months to a year. But for a CAD-E approval, the journey could be as long as 2 to 3 years. We went through the longer route. We decided to go for the CAD-E approval because CAD-E, the kind of category in which we got approval, covers the entire lungs technically, the lungs, the pleura, the heart, and the hardware. So the kind of study which you need to do to prove its efficacy and accuracy, that it is as good or comparable to an expert radiologist, is you have to use a large number of experts. And as a result, the study becomes complicated because it is also having something like a washout period in between. So if you look at it, it covers general opacity. If you see in the lungs itself, TB, pneumonia, nodule, atelectasis, fibrosis, lung mass, hernias, then opaque hemithorax, edema, calcification. In pleural conditions, it covers pleural effusion, thickening, pneumothorax, and covers cardiomegaly. And then in lines and tubes, most of those are seen in chest X-ray, in typically when a patient is admitted or in the IPD or in the ICU setting. And then we have to do clearances in different geographies. So that means we have to do, again, validation studies for this tool across different geographies. For example, the European Union, Thailand, Singapore, Malaysia, Indian CDSCO, Kenya, and Indonesia. And because it also involves public health and tuberculosis screening, then we have to also work with bodies like the Indian Council of Medical Research, with whom we're already working on a few pilots, and other bodies through which the system gets validated. So we also have image level where we have to showcase how every disease condition the AI is performed in terms of its AOROC sensitivity and specificity. Again, this becomes a pretty long journey. And whenever we go for approval for European Union, or we go for Singapore, or we go for UK or USA, we have to have their local data. That also makes it very complex and costly as well. And then we also have to look at the pediatric X-rays in terms of image level detection. So for the regulatory study for the US FDA, we had to do this over 15 US hospitals using 10 plus acquisition systems, using 3,000 X-rays, and then ground truthed by a panel of 3 expert US board certified experts. And then an unaided aided test was done by 24 US board certified radiologists over a period of close to 2 to 3 years, with a 40-day washout period, so that they've completely forgotten what they had reviewed. And then again, sharing those same X-rays in a random manner with the AI assistance, or it could be earlier without AI and then with the AI. And then we had to demonstrate the sensitivity, the specificity, and the accuracy of the area under curve. And basically, then if you see, we had to do both standalone test and then comparison of unaided and aided study. And in both, we were able to demonstrate that radiologists which are aided with AI were able to detect much better as compared to those who are unaided, because the AI as a virtual assistant can help them quickly look into the area of interest and focus there and make a report. At the same time, also demarcate the area. And because global health is very critical and important, we have been working with deploying the solutions in different geographies for public health, particularly in Africa, then Southeast Asia, and of course in India. And finally, after a round of 8 years, we received the WHO recommended, and now it is listed in the Global Fund catalog. That means organizations, countries and nations in different regions, including Africa or India or Southeast Asia, or even, I think it's a problem even in developed economies like the US, basically can look for the product on the Global Fund catalog and order for it like a drug. So basically it is a software as a medical device. So this is just to show how the AI output is seen. So this AI output is generated within less than 30 seconds. And it basically shows the abnormality either as a lung nodule, or it can be shown that abnormality present in the lung. So there are 2 or 3 different options which region or geography we cater to. We can switch on the right kind of output to be shown in that region. And it can be shown in outline view, heat map view, or a bounding box view. Similarly, tuberculosis or lung lesions will be shown like this with the outline view, heat map view, or a bounding box. It can also be quantified, and this information of the site and the zone is also taken care by the AI, and this information is noted. This is how a sample output will look for a normal study, and that's how the normal abnormal. So technically, the AI is excluded presence of these findings. And if it's abnormal, then the output will be shown in this fashion, showing this is an area of abnormality. It may either show it's in the lung, or if you choose the other output, then it will show it is a lung mass and also it will give the location and zone. So we also did studies, and we keep on presenting papers at various events like the RSNA, which is one of the important key conferences of radiology in the US, which we present every year. So this year also we have 3 research papers. And then we also present at Union, which happens across different nations, and it is a TB conference. And this was one such conference presentation where we at RSNA, where we were able to show that 4 different hospitals where we use the solution, we were able to get a precision of between 96 to 99%, and false discovery rate between 1 to 4%, resulting in a reduction in workload from 37 to 63%, with the error rate in clinical settings between 6 to 11%. As I said, as you can consider this as a junior expert or a radiologist, but as a result, effectively reducing workload by 30 to 60%. So one is how do we understand that the AI is making mistakes? And even experts make mistakes. Even if you look at the rate of experts making mistakes, it could be as low as 1.5 to 2%. It would be, some hospitals have reported as high as 10 to 11%, which result in a very complicated scenario. And because medical imaging, the expert is looking just at the images, and in some cases may have been fortified by some clinical history. But want of history or other things result in misdiagnosis or what we should say incomplete diagnosis also. So it's important in this case, though the ground truth is experts like radiologists, we can also take ground truth as CT scan reports. And it depends upon which modality and what disease condition you're looking for. And what the solution comes is that with the responsible AI module. So not only it helps in segregating normal scans and abnormal scans, it comes with explainable AI with smart reporting, but it also comes with the responsible AI, where in real time you will get to see performance in terms of decay and drift, fairness and bias analysis, and threshold tuning. So how does this happen? So let's say the radiologist mentioned in the report there is a nodule, and the AI is also saying there is a nodule. So if there's a match, basically that real-time analysis happens. If there's a mismatch that the AI said there's a nodule, but the radiologist did not agree, and we basically look at it as an overcall. And as a result of this, we basically understand how much overcall, how much undercall. So, and we need to understand what is the limit where the radiologist will say that this is the most balanced approach with this level of undercall, or I don't expect any undercall at some compromise of overcall happening. And that threshold tuning basically helps in setting up the use of responsible AI along with the solution, making it a real-time objective dashboard on the AI analysis. Because if we talk to a radiologist, and I'm a radiologist, I was practicing closely for 25 years. I was a professor as well in the past, and we are busy and we have multiple things to do. So what happens is, how do I get an objective analysis? Unless and until I don't document it on Excel. And that documentation basically helps us showcase how the AI performed in terms of the final radiologist report, because that will be taken as ground truth. And otherwise, it will just be more of a subjective analysis. And we have done now multiple research papers on the responsible AI model. And responsible AI model therefore becomes a separate tool from our portfolio because it is multimodal. It is fully vendor neutral. That means then it can be used for X-rays, CT scans, MRI, PET CTs, any modality where you have deployed AI, where it can be ground truth, which is the final radiology report, or any other investigations, including clinical histopathology, sputum, can be used to be as a comparison with the AI output. So the important reason why we need a responsible AI solution and why we really went ahead and created this solution is how do basically we build trust between AI and the expert? How do we ensure that AI is fair and free of bias? How do we explain the AI output? So the heat map, the bounding box, the outline views, all those are required. How do I tune the AI threshold? Because some organizations may consider something as an overcall. They may be willing to have some level of undercall. Some may absolutely not, like no undercall. How can we give feedback to the AI and we understand a gap? So if real world performance is what I'm saying is 99% or 97%, then in what is that real world performance? So that's something like a regulatory study. So how do I understand the real world performance of the AI, and how do I document it, and then how do I furnish it as evidence that this is actually objectively how it is performing in your institution? As a result, the productivity gain, what you're seeing is around 60%, 70%. So from zero, we have come to 60 or 70. So all this needs to be scientifically demonstrated. So these are just to show a few of the screens, how we track sensitivity, specificity using certain confounders of age, gender, ethnicity. And then how do we basically tune the threshold? We get also independently validated by organizations and audit agencies. One is by FIT, and this was a FIT study which was done separately and which showed the sensitivity and specificity matched the WHO TPP guideline for TB screening, which is 90/70, and the solution basically showed sensitivity of 91%, specificity of 89%, with accuracy of 89%. And the solution, we basically call it Genki, because Genki is a Japanese word for healthy, and we want the global population to be healthy. As a result, this solution is called Genki, and it matches the WHO guidelines. This I discussed. So how's the workflow? So building AI is just one component of it. We have to have the entire workflow around, and then only the deployment becomes successful. And this includes, it starts with the first solution as we built. which gets connected to X-ray machine, and the AI analysis happens. But then it goes ahead, and we also created a patient registration app. So all the beneficiaries, particularly in the TB screening workflow, will be screened, and then the AI triaging will happen. And based on that result, within 30 seconds, you will get option to collect the sputum or swab, because there was a period where COVID and TB screening was happening simultaneously. And because incidentally we were picking up a lot of COVID, and it was a few years back, obviously, and now. And so basically that workflows could be initiated. And this system works completely offline, but then it also connects to the cloud platform, as in when we have access to the internet, or when this WAN comes in access to internet. And then you have one more level of review by expert radiologists. So now you have a ground truth as well. Or it could be even hospital physicians. Now you can draw model decay drift, fairness bias, and threshold tuning. And then as a result, you also get a lot of analytics. Therefore, every beneficiary scanned at the grassroots gets documented, and nodal officers sitting centrally are able to see the command and control center. And that's the entire public screening workflow. So we have been doing camps um, in different geographies, and we have got different results, which ultimately becomes publications at some point of time. But we have been working primarily with nations. One is Singapore, where we have been in deployment for last 3 years, where our primary area has been the platform deployment. So we have this platform which helps us in screening, and that has been deployed here.
Excuse me,
Yeah,
sir.
yeah, sure.
Sorry to interrupt you. Please, can you show the previous slide?
Yeah.
Before that, just 1 minute, sir. I want to take snapshot. Before, after that,
Yeah.
after this slide. No, not one. This is before, sir. After one. After this slide, sir. Wait, yes, sir. This one, sir. Before case study.
Okay.
Before case study, sir. Wait, sir. Wait.
Yeah. Please let me know when I should continue. Is it okay? Should I move ahead or should I continue?
Continue, sir.
Yeah. So so we have been working with different geographies globally, like in Singapore. We have done a lot of research around this, how it has improved productivity. And we were able to demonstrate in the last presentation at RSNA that we were able to reduce the report generation time by around 73%, reduction in turnaround time by 91%, and critical patients were able to be prioritized because of this. This was a study which we did over 1,000 patients, prospective study over 1 year. So we ourselves provide chest X-ray reporting across the country through our own organization. And we started this in 2017. That time we did not have the platform. That time we did not have our AI as well. But we have transitioned to 2025. We were not doing any X-rays then. Today we do more than 2,000 plus X-rays, providing service to every corner of the country, primarily with the privately owned imaging centers and also public-private partnership-based centers. So we also did a feasibility testing for deployment of this platform in Bhutan, awaiting funding for the deployment. The feasibility testing is done. A few large imaging centers in India are on the platform. Large hospital networks are already using this platform and the AI. Working with a lot of different states. One of them is Tamil Nadu, where we have deployed since 2019, more than 5 years. Screen using this solution, more than 15 districts, screen more than 500,000 patients. And this was in conjunction with Clinton Health. And using this solution, we were able to increase the yield of presumptive TB by 25 times. So before AI intervention and after AI intervention, and multiple research papers are coming out of this, and you'll see them in the public domain very shortly, which talks about how conventional X-rays versus digital X-rays, how the change has happened using this solution. The more and more sites across the country are now, and multiple X-ray manufacturers are looking at this solution. And as I said, we have been working across different sites across Southeast Asia as well. So that's the overall kind of perspective which talks about how the AI has been used in the public health as well as in the clinical, and how this entire journey from the product conception towards product development towards real world deployments. Before that, validation, regulatory clearance, and then now commercial deployments. So this entire journey is something that which I showcased. We have a entire technology platform, and at some point of time, I would definitely like to showcase that as to how this platform works. But this gives an overall a snapshot, and if there are any questions, happy to take.
So which algorithms you have?
I'm sorry. I'm not able to hear you, sir.
Yeah. Which deep learning algorithms you have used for this? Diagnosing this chest X-rays, all those things.
Right. So I'm not a very technical person, and so basically this entire tool is a deep learning tool, and primarily whatever tools what we have demonstrated are the deep learning tools only. And the second important point is all this data annotations as well as the data validation just happens in-house, because we have a large team of radiologists, around 140, and they become our independent validators and annotators of this data. And before that, before we go to the external validations for validating this, but this is a fully deep learning based algorithm.
But how can I use this deeptech.ai?
Right. So basically, for that, this comes on a platform. So this entire algorithm can be deployed on a platform as a standalone tool, and basically it sits on a laptop. As I said, it's an edge solution, and then you can connect it with your X-ray machines, and then you can utilize this and then do your own internal studies or validation. So we typically, when we do that, then we work with a research MOU with the university. We have multiple research MOUs with multiple universities. Then after the MOU is done, we basically deploy the solution. You may take a license from us for a few X-rays. It could be a few hundred to a few thousand. Then basically everything depends upon the university to get the ethical clearance and then validation, and then finally resulting in a joint research publication or independent validation exercise as well, whatever is the right approach.
Okay, sir. Thanks for your information. Thank you.
Sir, I have one question. Can we use means only chest X-ray means it is possible that we diagnose TB by only using chest X-ray, or clinical data is also required, sir?
Very important question. Actually, TB is a very complex diagnosis. Chest X-ray is just one of the paradigm which is there. Finally, it is a gene expert test which is used for confirmation, and that's the most critical test. But what the chest X-ray does is shortlist high suspicion X-rays where we see evidence of finding. So these patients can 100% be directed for the gene expert test. Previously, it was only based on clinical. Then in some cases, family contacts plus clinical. Then where X-ray machine is available, then with the X-ray as well. With the AI on top of it, then you know which, if you're doing 1,000 X-rays a day, all patients may only based on clinical and chest X-ray cannot be sent for a gene expert, because gene expert test also costly. So the AI act as the chest X-ray AI acts as a triage tool. It triages the correct X-rays and showcases or takes them only for the sputum test. So that's how it has reduced the cost also. Otherwise, such a large population undergoing gene expert versus those which are now shortlisted by AI as highly suspicious for TB undergoing a chest X-ray, a sputum sample for a gene expert test becomes easier, and that's how the overall cost has come out. And that also is a separate research paper which we should be available in the public domain in the next few months.
Sir, I am actually doing research
Right.
in one of the Mumbai institute, and I have contacted you. I don't know you remember or not, but my name is Saili Salkade, and I am from this Mumbai.
Good.
So I am Mumbai University, and I have contacted you regarding some X-rays. So
Right.
data part. So at
Correct.
that time, means you told that it could not be available. So is it like we can have a collaboration, or your institute is collaborating with different researchers to give such X-rays so that they can also contribute to research?
That's a important point. So we don't give data. We give a solution to you and you validate the solution. So that is how basically it is. We are not a medical institute or a medical college. So primarily validation of this will happen in a medical institute or a college. But if you're looking for data, then there are multiple data sources available, like the chest expert and so many other sites which give different data sets. One of the largest data set is basically the chest X-ray globally available. And I think that is what ideally most of the algorithms could be developed on. But the problem with these data set is incorrect labeling. So if you look at the labels on this data, these are absolutely not correct labels. Majority of these labels are incorrect. This needs to be fully looked into in a separate matter. You need to have a radiologist inside. You need to do first level, second level, third level of curation before you actually go ahead and start doing the data annotation. Otherwise, the basic fundamental data set itself needs a lot of correction. So when you use this data, this always has to be in support of a group of radiologists. Of course, you'll require along with not, it's just not about data, because you need to be as certain that the annotation is correct on this data or re-annotate the entire set. So we typically hand annotate this data for the last 8 years, and this is a never-ending exercise. Till date, we continue doing that because every algorithm, even after that, we need to keep on improving and making it better. And it's a not only a costly but time-consuming activity. But after that, you'll reach a certain level of accuracy. So it's not something that can be just be done over a period of a year or something like that. But if you're developing something independently, if you're looking for data, you have to go to medical institutions and medical universities. What we will give you is the AI algorithm on a platform.
Okay, so sir, so if we can contact, means I can contact you, can suggest me some AI algorithm which you are using, or then we can enhance that algorithm and help you out. Like that can be done.
So for us, we cannot enhance the AI algorithm without further regulatory clearance. For example, if I do some changes in the AI algorithm, we again have to go for an updated regulatory clearance. So what algorithms come, they come in a locked-in state. The algorithm is always locked in by the FDA. I can't add any new pathology. Whatever pathology I document in my regulatory clearance is the pathology that I will be able to give. What happens, what research we'll do, we'll have to come up with a updated regulatory clearance for that. If at all we bring any new tools, for example, we want to bring lateral X-rays, or we want to do something around quality in X-rays. So this will be a separate clearance. And again, this takes again the next few years will go in this journey, in this entire process.
Sir, I have one more doubt, sir. Sometimes in the X-ray, the operators, they don't know how to fix the radiation level within the limit. Because of that, if they exceeds the radiation limit beyond that, means if they pass that extra radiation to the peoples, they are get affected by the cancer. So, because if there is any other method is there to avoid to pass that extra radiation level to the peoples, because we need to take precaution, because we don't know about that operators, because all the operators, they don't have the knowledge about that the X-ray machines and at the radiation level. Sometimes they do some mistakes because of that. Most of the peoples, they don't know, they are indirectly affected by that radiations like that, because after 1 month or 2 months only they know that they are affected by the cancers, that kind of disease like that. Because how can we avoid that kind of situations? Is there is any AI methods or automatically adjusting that radiation level method is there to keep the people safe, sir?
Very important point. Actually, First of all, I want to remove certain misconceptions also. Um, um, Whatever X-ray radiation dose that comes is typically in millisieverts or very, very less. A typical CT scan chest will be 1,000 X-rays done in a less than a few seconds. If you do a cardiac CT, it will be again more than thousands of X-rays of a chest done in a few minutes. So a chest X-ray versus a CT chest versus a person undergoing multiple CT chest, you can see the difference. 1,000 X-ray chest is happening. So the radiation dose which is going from a chest X-ray is absolutely minuscule. Secondly, radiation X-ray done and a cancer happening, something, this is a complete misconception. This is a complete misconception. There's nothing like you do a chest X-ray and the person will get cancer. It's just a coincidence because whenever chest X-rays are done, there is a stochastic, non-stochastic effect. So I think you must be knowing about radiation. So you cannot predict which patients will get, but at the same time, we know. So we follow the principle called ALARA, as low as reasonably possible or available, whatever it is. That and the time, distance, and shielding. These are pretty critical areas that we need to look into. So time means the lowest possible exposure, distance as far which is around certain feet distance, and time and shielding. That means the parts which are not going to be given X-rays need to be shielded well. This shielding basically indicates sorry, yeah, time, distance, and shielding, and the shielding which indicates like gonadal shields or thyroid shields. And if all this is followed, I think there is absolutely more benefits than harm because of any X-ray. And secondly, the kind of X-rays which are used for portable screening are handheld X-rays. So their output is absolutely low. And X-ray machines have a safety lock that you cannot keep the button pressed. It's just a shoot and release function. So otherwise the tube itself will go because the tube hits and then the machine, the X-ray machine gets worn out very easily or early. So I think I hope I have cleared any kind of facts about how to use X-ray machine and how much X-ray exposure is permissible. For example, healthcare workers like us, if we work with angio and those who work in the cath lab are already getting exposed on a daily basis over 365 days. And they are continuously doing coronary cath angios or some other angios, and the kind of radiation they being occupational workers is very high. So we all have dosimeters on top of that, which is capturing any kind of X-ray going above that particular level. So chest X-ray screening is very valid, like breast cancer screening, very important, and more benefits. And rest in terms of radiation related malignancy, something those occurring within months cannot happen. Technically, it takes years for cancer cell to build up, and there could be multiple other reasons for cancers to happen.
Thank you, sir.
Excuse me, sir.
Sir, I have one
Hello?
more question. Can
Yeah.
you tell from research point which things can be done in TB? I'm doing research in TB. So can you suggest something in the chat box, or like you can just
Yeah,
one or two
correct.
can be written?
Important point in TB research is now that TB is one is detecting TB. Second is probability of active versus old TB. Are we able to go and deeper now? Then pediatric TB. The third is silicotuberculosis. That is areas where silicosis and tuberculosis are coexisting, and differentiating TB from silicosis. And these are important questions which in the future will come for more answers from AI tools. So basically AI getting more and more differentiated now. And that could be the journey most of the AI products will take in the future. So if at all you are doing research, I think these are areas that you could focus on.
Hello,
Sir,
sir.
you told TB and silicosis. No, sorry, can you type in? Just type down because it would be easy for me. 1 or 2 points. Okay, sir. Yeah, got it. Thank you so much. And sir, can you share your email ID if we have some problem. Then there is one more presumptive TB also I have heard. Actually, I got stuck up in point that subtypes of TB. So there I saw that X-rays are not self-sufficient for your TB diagnosis.
Correct.
So
There are
we
four
require
to- yeah,
DST or
there are 4
these
to
things.
5
No?
types of TB. We have um, basically the nodular, caseating variety. There could be lymph nodal TB. There could be a bronchoalveolar TB. There could be a miliary TB. Then cavitating was one of that. And sometimes it could be in the pleural space. That's the pleural TB, pleural disease can happen. So no part is immune, including the chest wall from TB. But the commonest one, which will also be sputum positive, will be the one which will be the basically the cavitating or the bronchoalveolar variety, which basically disseminates and is result in a sputum expectoration. The other varieties sometimes may even be sputum negative. Sometimes it is very difficult for patient to expectorate or give a sputum. And sometimes if the patient is immunosuppressed, again in that particular situation, it will be difficult for the patient to expectorate, and or in that case, even if that happens, we may not find it to be positive on gene expert. So there are challenges. In certain cases, pediatric patients also find it difficult to expectorate and may not necessarily be positive on gene expert. So considering all these things, TB diagnosis becomes complex. So clinical history, family history, known contact, weight loss, fever, chest X-ray, and all these together, we basically then finally take a call and then decide what next.
Hello, sir. Sir, why did you
Okay, sir.
choose
Thank you.
Sir, why did you choose X-ray, deep learning for the X-ray, not for other reports like echo or DTP or something else? Is there any implementation problem or something?
No, I think there are hundreds of AI companies today, and every AI company is working in different space. There are companies which are working in the echo, someone who's working in the ultrasound. There are companies working in the CT lungs for CT lung nodules. There are companies for CT pulmonary embolism, companies looking at CT brain for stroke, MRI brain for stroke. There are a lot of musculoskeletal AI companies looking for fractures, pediatric and bone age. So there are hundreds of companies today doing all these things. And one company cannot choose multiple things, even they are well funded or they're starting bootstrapped. Healthcare is very complex, as you can see from the chest X-ray workflow. Even chest X-rays have multiple workflows: pediatric, adult, clinical, visa, or TB screening, and then the entire workflow around it, right from patient registration to responsible AI, and validating those outputs and continuously updating and upgrading. And how we can do normal. The future is how good AI will be in doing abnormals as well. Writing a full-scale report where radiologist does not have to do many things but just sign off. That journey also is very long and complicated for abnormal reports. And AI will undergo multiple iterations before it reaches there. So similarly, similar complex journeys exist for other companies looking in pulmonary embolism or echo or ultrasound or CT brain. Journeys with healthcare is very complex, and a single company should ideally focus or not more than 1 or 2 products to ensure that they have a product which becomes usable and adopted in the market.
I
Hello,
see,
sir.
sir. Thank you, sir.
Hello, sir. How explainable AI has been addressed by this chest X-ray AI solution?
So as I said, I basically briefed in the call as well that the radiologist output gets to be the ground truth and the AI output, and both of them are then correlated, and then the dashboard is created, and it's a real-time dashboard. So if in that particular day AI called 20 nodules, but the radiologist only labeled 5, then basically you come to know what exactly is the accuracy of the AI, how much is the overcall. And what the cases where the radiologist called a nodule, but the AI missed. So that is the undercall. So that is why the responsible AI is a very, very critical component, because it gives an objective real-time assessment of the AI and um, the ground truth, which is the radiologist report. And as I said, in the future, you can add more ground truths also, like a CT scan, or depending on which disease condition you're looking. For example, if you're looking for TB, then you can also add to that gene expert results.
Sir, before deployment of the solution in the testing phase, what is the value of that specificity and the sensitivity? Means what is the value at which it will be sure that now the solution can be deployed?
Yes. So as I said, WHO has guideline 90-70. For TB screening, it is 90-70. So your product has to meet and exceed those guidelines only. Then it will be basically utilized. So if you there are multiple papers, research papers. There are few even in Nature Scientific Research, where our product, deep tech product, is also there. And if you look at that research paper, they have compared other AI products in the same kind of genealogy, where they're basically looking at TB. And then every product's performance is benchmarked. And the benchmark here is radiologist report and also sputum sample. And finally, that they already have a test sample. So when they audit across that using that as a test sample as a benchmark. And the minimum guidelines is your product should have 90-70 to even qualify inside. Then after that, it is basically benchmarking your product against other similar products in the industry.
Sir, sorry, sir, I didn't understand 90-70.
Sensitivity and specificity. 90 sensitivity and 70% 70 the
Respectively.
specificity expected for TB screening. About that product has to be about that.
Specificity is 70%,
70%.
sensitivity is 90%.
Yes.
Thank you, sir, for the clarification.
Thank you, sir. Thank you very much for your insightful talk and very good interaction with our participants. And you are very briefly and explained about the chest X-ray and the tuberculosis diagnosis, all these things, and how the specificity, sensitivity, and relates with the diagnostic tools like that. Very much good session. I also learned many things. I am also doing my research in medical imaging. Thank you, sir. Thank you very much.
Thank you. Have a good day and enjoy the rest of the sessions.
Thanks. So, dear participant, the next session will start just after 5 minutes. That is 7:30 p.m. So, please stay tuned.
Hello, good evening to everyone. The organizers, I request that if you can allow to start the session.
Yes, sir. Mr. Yes, sir. Yes, sir. You send me, sir. Yes, yes, yes. Sure, sir. Sure. So I welcome you all to the second session of first day. And in this session, our research person is Professor Avinash Sharma. He is presently Pro VC at City University, Punjab, and worked as Director Engineering at CGC Mohali University from 1st November 2023. He earlier worked as professor and former principal, awarded as the best administrator, Maharshi Markandeeswara Engineering College, Maulana, Ambala, Constituent Institutions of Maharshi Markandeeswara, and now associated in NIRF ranking, NIRF innovation as nodal officer and IISc president in Maharshi Markandeeswara College, deemed university, and QS Asia University ranking and other national international ranking process and NBA. Also Dean Faculty of Engineering and Technology and member of Board of Studies and DRC Committee for Research, former Director and Professor, Rajasthan College of Engineering for Women, which is a leading women's engineering college of the state of Rajasthan. And previously also Principal and Professor at Maharshi Markandeeswara Engineering College and Director Rajasthan Engineering College and Founder, Principal and Professor of Aditya Vedanta Institute of Technology, Agra. So in these introductions, I invite you, sir, Professor Avinash Sharma, sir. So now the session is yours, sir. Kindly share your screen, sir. Yes, sir, it is visible.
Okay, we are going to have a session today on the medical imaging techniques for the COVID-19 related diseases. As we already know that these kind of diseases has been very much troublemaking for all over the countries across world, and we faced major challenges in the year 2020 and again in 2021, and the fear of the COVID related diseases is not even gone today also. We are going to see many future pandemic situations where we may use the different technologies which are available, and specifically the medical imaging techniques. So these techniques which has been used during the COVID-19, and even in future we can apply these techniques in the healthcare sector with the help of various algorithms, even during the coding and everything we are going to explain in the session. So with my self, Dr. Tarkeshwar is also there. We had done a very good extensive research in these medical imaging techniques, and we are going to explain all these things to you, all the participants. So we are going to have a good hands-on session. So I request everyone that if you have your laptop available with you, so you can start some coding with us, and you can learn something new from this session. So, Dr. Tarkeshwar, can you please elaborate on these topics again, please?
Thank you. Thank you. Myself, Dr. Tarkeshwar Barwa. I will be heading this seminar. So this nowadays, as sir explained, pandemic is may come in next anytime. So that's why we are taking a reference of COVID-19, and not only COVID-19, and we can take imaging technique and any other type of disease we can identify. Just we need to mark, and based upon that trained model, we have a available trained model available online, and these models we can download. This is how we can save a computation. So as we proceed in this, so if I talk about, so you must have to have installed a Python on your machine. So in my case, I'm using Python 3.12, or any version of Python you can use. There is not a mandatory that the same version. Or if you are if you don't have a Python on your machine, you can go with a python.org, and you can download first. So I will not download. I have already in my system, so that's why I will not be downloading. Just I'm sharing the link with you, so that by the time being in the background you can execute. So this session is a completely hands-on session. I will be explaining this from scratch, and any IDE you can use, like a Jupyter Notebook. In my case, I will be using PyCharm, because I have developed all these.
Someone is asking that whether we can use the Google Colab or not.
Anyone, yes, we can use. We can use. So as I said, you must have a Python installed. Any platform, may be remote or in the local platform. You can use Google Colab. No, because I feel good in the same, but I will be sharing the code and explaining. So you can use, you can just copy paste, or you can type the code with me. So both are fine. So it does not matter. Okay.
Sir, kindly share the code in the chat box.
Definitely.
So that the participant can copy and paste that one.
Right. Absolutely. So
Sir, at the same time, we will be taking some theoretical part also, that what are the various techniques and how they are incorporated in this coding. So it will go parallel hands-on session. So those who are having the laptops, they can directly practice it on their laptops because we'll be putting the code as required in the chat box, and then they can simultaneously execute it also, sir. So this will be quite
Sir,
helpful.
good evening, sir. If
Yes,
possible,
good.
can you share the documents in WhatsApp so that we can copy in that and we can do that one? Because only
Yes,
small.
yes, sir. I will try to make it both the things simultaneously possible. Okay, no worries. No.
All right. Thank you. So, all right, let's proceed. So once you have all this environment set up ready on your machine, then everything will be fine. In my case, I will be using a PyCharm. And if you want to, if you are willing to use a Google Colab or any other platform, you are free to use. Because I have industry experience, so that's why all the code is written along with the comments, required comments. All right, so let's proceed. So in this research or in this, we have we are providing the necessary context that highlighting the global challenges of global COVID-19 pandemic. So it's a more importantly, we need to take some images. I have a repository. So this is the repository, online repository, from where I have downloaded some images. These online images are already available. You can download and you can put on your local machine so that we can find whether this particular image is identified as COVID-19 or any disease effective or it's a normal image. So let's proceed. So in this list, the key role of imaging. So we are applying the technique called image recognition from the diagnostic and monitoring. We are diagnosing and monitoring, which is immediately communicates the relevance of importance. So let's assume uh, you are or anyone, one of your somebody got one disease and got doctor required some attention on it. So it a doctor can identify or machine can identify with the help of prior images. And these images looks like this. I'll show you this, what type of images we have. So this is the one. I have images called these one. Let me show you these images I have. So PNG images I have this one. So this type of X-ray images we have. So if you talk about in the first one, in this there is no spot is recognized. So that's why this is this image is completely neat and clean,
Sir,
normal.
these images are present in PNG file, no?
Yes, in the form of PNG file, because PNG files are good and low data means you can say it require less amount of storage and there is no pixel raster images available into this. It's almost type of vector image. That's why we have selected PNG. Dear participants, if you are not speaking, please mute. And I will tell you some insight into this.
Adding to this, I want to tell you that the PNG files are most suitable for the maximum kind of developed algorithms in Python.
All
And
right.
some of the images are not compatible. So I'll always use the PNG files. And I request all participants to please mute yourself in order to better understand the algorithms and coding.
So in this research, we are including total 443 sample files, or samples maybe more than that. And we have some pictures. Few are classified as a normal image, few are affected image. or some other type of disease. So here we are going to discuss about the roadmap, how we will proceed in this type of research. So let's take an example. So first, in the introductory, just now we have started, we are providing the context of COVID-19 global challenges, and once another one is answer the why medical care images is important. So these two things should be comes into your mind first, then only we can proceed towards the research. Then once you find the curiosity, then you may proceed with what is the role of imaging techniques, and finally this road goes to the research. So this is the chart that's we are going to follow this chart. So what we have in this presentation actually. So especially if we talk about, first we need to identify the role, what is the role of imaging technique, and how we are going to identify them. And if once they are identified, whether they are classified correctly or not, so automatically error correction also available into this. Especially we can use two types of technique. If you talk about the basics of image recognition, we are using CNN or RNN. So now many researchers, they are very confused about which algorithm is good. So straightforward, I can say CNN is the best for grid-like structure. Means somewhere you have a pixel-based structure, grid-based structure, while RNN are designed for special data where order of information is matter. Order of information matters. So let's take some example of this. For CNN, like image recognition, video recognition, medical image. So obviously we are going with medical image. So that is the reason we have selected CNN on priority. And autonomous vehicle, in autonomous vehicle, we are identifying the images like a traffic image, a car image, or any type of images for recognition we can use. Even CNN is good for natural language processing. We call it NLP, because this is always giving you the fast response. On the other hand, if you and NLP is a very diversive, and this is very gentle. You can use RNN or CNN. In both cases, it is giving you good results. All right. But if you talk about especially on the RNN, best RNN we can apply for speech recognition, time series database, or music composition. Okay, that is the reason. So we are going to use image recognition with CNN. So what is the background of this entire research? So this section served to remind the audience to unprecedented nature of COVID-19 pandemic by mentioning the unprecedented challenge for healthcare system. It is highlighting that this was the crisis on global scale that require a new or innovative approach for medical care. So why it is needed? So in 2020, we have faced COVID-19, and tomorrow new disease may come. So this type of exercise can help us to identify new type of novel disease, but we can name it later. So one question is coming. What is that? All right. So here we are selecting a data set, image data set, and this data set is already available on Git repository. I have already shared this Git repository. So you can go with this Git repository. This is the Git repository. Under the PNG, this is the repository. And if you want to download dataset, entire dataset along with the images, complete dataset. But I have my own everything. So I'm going to use CNN. So that's why my concern is only to use images, not this dataset. This dataset also available. This dataset freely available. You can use this. This is CSV file, but we are not using this CSV file. Each and every image have a certain record. All right, now let's proceed. So by mentioning the unprecedented challenges in healthcare system, it is highlighting that this is a crisis for global world. So in this set of stage, the next point which we intermediate new need of medical imaging, and doctors may be busy with other patients as well, and if they go manual image recognition or what is the problem in the x-ray, it takes a time. What if doctor will get the conclusion? So this is how uh, anyway machines cannot be that much faster, that much efficient like a human, but machines can help us, help doctors to find reach on certain conclusion. So this conclusion may help correct medication. So this background text positions the imaging as crucial tools that was not just helpful but necessary for navigating the complexity of disease from diagnosis of management. It provides essential why behind the entire presentation, making it very clear and outside technologies. So this is a flow diagram. We have proceeded and we have conducted this research long back in 2020 itself. And still this model is getting enhanced, getting trained and optimized, getting optimized day by day. And as much as you will provide the data, model will get trained by itself.
I interrupt here, Dr. Tarkeshwar. If we get the time, we will show our some of the models which we have developed and
Yes.
a few of the reference of some research papers which we have written for the what you can say better understanding of this pandemic related diseases and medical imaging technique, especially in the year 2021, that is the third phase, and then their future conclusion also. So that will help a great insight into these kind of models.
Yes. Yes, sure, we'll do that. So if you search about us, Dr. Avinash and Tarkeshwar, and if you search on the Google, and you will find many research paper and books we have published together, and articles, research papers. In the research gate, where you can find these all research related to uh, image COVID-19 recognitions. You can see these reference papers you can download. I'm sharing this one with you. So please download accordingly. And I will explain each and every research paper, what we have published. All right, now coming to the presentation. So especially what happens, this data we have already implemented in our one of the project. So we are collecting data, medical sensors. We have implemented IoT, and as image is captured, immediately we are generating data, and based upon that, we are performing analysis image, as well we are storing data in MySQL. We are using MySQL dataset to store. So IoT devices, they are collecting data, sensing data and stored with the help of router switches. It is getting stored in one of the place. We have a warehouse, their data is getting stored, as you can see in the flow chart. So let's come back to the little coding. I believe many of you have already downloaded this one, and this is the link. I will be sharing this link with you just after this meeting.
Sir, please show the previous slide. 1 minute, sir. Please show that
Yes.
slide.
This one?
This one, yeah. Sir, hold 1 minute. Just I will note down.
Yes, please.
Later on, we will share this PPT on your
We will
chat box
share.
also.
Yes.
We will share it. You can take your PPT for all future reference. That is not an issue.
Or you can take a snapshot.
Yes, sir. I did the same, sir. Thank you. You share later on, sir. Please. Thank you.
Yes. Okay. Thank you. So here, what we are going to use, so once we have installed library, so we have a NumPy. NumPy is a very common for numbers calculation, because binary data is image data in the form of 0 and 1 images. So that's why for number calculation is required. And TensorFlow is nothing but is a framework developed by the Google for image recognition or huge amount of computation. And then TensorFlow, we have loaded a model. Predefined models are available, because if we train our own model, it requires a lot of time. So that we don't want. So few already available models we can download and we can train them. So it will take, we can save time. And before processing any image, we require to resize image, or sometimes images may not be correct as per the standard. So automatically these images can be resized as well. Like this one, these all are images already filtered, but some images may be blurred, or maybe tilted, or it may be defected image like this one. So this image is not up to the mark. So this image can be cropped by itself. So image processing is required to fit these type of images in our model. So this is a completely automated model. So we have created one function called load disease model. By default, this model is available. Just we are install providing some details, like with the help of keras, one flatten layer, the image size we have provided, because we are considering the left, right, and top 3 axis image. And for this one activation function, we are using ReLU and softmax. So we have find the best results while we have combined ReLU and softmax as an activation function. Activation function is nothing but which pixel should be passed as a correct one, and which which pixel should be dropped. So for that reason we have used. And once this is the definition of model, once this model we got in the system, then we need to compile, we need to prepare it, and we are using optimizer, Adam optimizer, and matrix cross entropy we are using. So and cross entropy will help us to segregate the data and then collect it at one place. So this is helping us to load conceptual model. And in case anything went wrong, it will raise exception. So the first function I'm sharing with you, So just you can copy paste. I'm sharing in the chat window. And
Sir, that load model we have to load, no? That H5 dot H5 file.
yes, yes,
So that will be different path to
yes.
your model dot H5.
No, right now we just instructed this type of model we are expecting.
Okay, sir. Thank you.
Thank you. So we have provided some, so this is long code. Some comment I need to delete. Okay, no worries. I'll do one thing. I'll share twice.
Sir, if any link is there, you can share that, no? Means instead of sharing, copy pasting link is there.
Right.
You can do
I
that.
will share the entire file.
Yeah, it would be better, sir. Means no errors will be there.
Okay, fine, fine. That's true.
Thank you.
So I'm sharing the file. There is no chance of making a mistake.
We'll be sharing more additional link also for your future reference. So those particular links also you can try later on. We'll do all the other links also for your reference.
So what you have link provided in the GitHub,
So please share. It's already shared. Please check.
No, sir. Please listen. The PNG images are not getting downloaded from the GitHub.
Okay, I'm telling you, please. So please, everybody, please open the git cmd command. Just cmd, and wherever you are, just pass git space clone, and then put that link, the one I shared with you. So the entire repository can be downloaded like this. This is the command. So the entire command I'm sharing with you.
So Git is not recognized as an internal or external command.
All right, no problem. If you do not have a Git, no problem. You just go with the Play Store, or you can download Git. Git also very small software. Git download. So just search Git download, and this is the link. Very small software. You can click here and you can download and you can install. All right, so now let's proceed. So in this code, so in this section, the imaging went beyond the just a single use and becoming a multi-purpose tool for healthcare professionals. Doctors can use this tool for different purposes, not only recognizing a particular disease. As per instruction from the doctor, we can retrain again and again, and we can classify different diseases. So first, we need to, these are the 4 steps we have into this. First, we need to diagnose and confirm. So in this, we are providing a visual method. Just visually, we are watching this to identify and confirm whether the virus effect is available in the lungs, which is especially critical when lab-based tests are not readily available or took too long. So for COVID-19 report will go to the pathology lab and they will test, and it's a very time-taking process. So And then accessing disease severity, what type of disease severity it is having. So AI can help, or this model can help the percentage of image, what percentage of affected image is there. So it is allowing doctors to see the extent of lung damage, inflammation, which help them understand how sick a patient was and determine the appropriate level of care. Then monitoring the treatment. So once the things are started, parallelly we need to identify whether patient is recovering or not. If recovering, then what is the percentage of that? So it is enabling the clinic clinician or
It is
doctors
showing
to
this error.
uh,
After downloading Git and then putting in
uh,
command from this Git clone
okay, no
command.
worries. Do one thing, you can share your screen if you I can help you on this. Okay, whenever you are ready, you can share your screen. All right. So doctors can track the patient progress over the time and see if treatment was working by comparing the image results
Sir,
from
I have
different.
shared here.
Okay, let me stop this. Yes, I can see. So yes, the command is wrong. So just type here git space clone, git space clone, and then paste this URL, git space clone, clone space, and now paste that URL. Same. HTTP get clone. Yes, right. Correct. Paste now. Enter. Okay, you don't have a Git. So open the browser, Google, and search Git download. Git download. This is a small software. You need to download first.
Sir, downloaded and installed also, sir.
Yeah,
Still
show
it
me.
is. Yeah, sir.
Then okay, then close this command prompt. Then close this command prompt and open once again. Clone, close this command prompt. Yes, open it once again, and then definitely this command will work.
So is it Git clone?
All right, shall I proceed now? All right. Okay, once then differential diagnosis. So differential diagnosis is helping to rule out other respiratory disease, like one disease, pneumonia and COVID-19. If pneumonia and COVID-19, if I want to compare, then how much they are different. So the differential diagnosis also available or possible with the help of this type of image recognition. So it might be similar symptoms, ensuring the patient received the correct diagnosis and treatment. So this is the diagram for this. So first imaging technique we are applying and diagnose, confirm with the help of visual method and to confirm. And after that, accessing the severity. If patient is affected with the disease, then how much is the, what is the severity level? And then once we have find the, then we have to proceed with the monitoring treatment. So how fast patient is getting recovered and differential diagnosis. Parallelly, we are treating the patient with one disease and see parallelly another disease also identified. So this can help to identify other diseases as well. So it's nothing but it is able to find the difference between the one image to another image and how what is the percentage it is matching. And medical imaging becomes crucial tool for diagnosing, confirming COVID-19 infections. So across the world, this technique is being used and it is commercialized almost, and accessing disease severity, progression in the lungs, monitoring treatments responses, and ruling out other causes of respiratory illness. Right? Shall I proceed? Now the best place is X-ray image. Chest X-ray image is the best way to diagnose. So in this, we are exploring the primary imaging technique. First, we will do the CNN and then we will apply the RNN. So according to my research, CNN is performing well because these type of images are grid image. So X-ray can understand, known as the first line of defense. So use a small dose of ionizing radiation. And nowadays X-ray, some people can say, sir, X-ray also injurious for body. Yes, that is true. But here we are taking a light images, not heavy images. So obviously this is not good for health, but at least somewhat radiation it will affect. So chest X-ray images are focused on the first line of defense. It uses a small dose of ionizing radiation to create images of inside the body. The diagnosis and confirmation, then accessing the disease severity, monitoring the treatment, and differential diagnosis. Chest X-ray image is often used as a primary or initial imaging modality due to its speed, availability, and low cost, because it's available at uh, almost all cities. That is why we have selected this technique. So chest X-ray images played a crucial role during the COVID-19 pandemic, especially early stage, for several reasons. What is the reason? First one is speed. Just you need to upload the X-ray image, automatically it can identify. And X-ray images, X-ray machines are available even small town. In fact, some small remote areas as well, and it is a low cost. It is not in India. Government of India has announced free COVID test, but in this case, it is not. That time, this technique was very useful. Free vaccine, many things are provided. So chest X-ray images can perform and interpreted within the minutes, very quickly, not even in minutes, and it is providing a rapid initial assessment of patient respiratory status. X-ray machines are widely available in the hospitals, clinics, making them accessible to the limited resource settings. So this is a diagram in X-ray image COVID-19. Now let's proceed. Hopefully everybody has set up the environment. If anybody facing any difficulty, please feel free to ask me. And at any point of time, if you stuck or if you lost somewhere, immediately you can read the comments. Comments are very important. And these comments are self-explanatory. So you will lose nothing. So first method is done, function is done. Next, we are moving towards the pre-processing of images. We understand there is the chance of images may be wrong. So that's why this code can resize images or make changes according to the requirement. Automatically, nothing is to do. All right. So first it will load image. From where it will load the image? So image path we will need to provide. From where it will load, we need to provide the image path. And what is the size we require? We require the image size is 224 by 224. If you increase, it's your choice. So if you have a large images, you can select the images 224 by 224. So as you can see, this is the size. And if you want to measure, only this much of sizes we are considering. So you can see on the bottom side, the size of the screen, resolution of the screen. So many of the images are around 600 by 500. So this is a target size. You can change, you can resize, it's your choice.
Excuse me, sir. Sir,
Yes.
by reducing the size of the original image, won't it hamper the performance of the algorithm?
No. Yes, if you make a big one, we need to set the threshold for this. Like my image is very big, but you are targeting only small portion of the image. So there is a chance it may affect the accuracy.
Is there any threshold, sir? If the image size is 1024 cross 1024,
Then you can
how
enter the entire complete size. Like I can make a, see if I change here, see here, if I change it, usually 500 by 500. So I can take here 500 by 500. I can take it. So it will take this much of size, 500 by 500.
so
But
it will
maybe
increase the
possible.
complexity of the program.
Yes, right. That's true.
So is there any threshold that up to how far the image size can be reduced?
75%.
75.
75%. So
Okay, sir.
usually threshold is 75%. Whatever the size, width or height we have, so we are usually considering 75% of the image.
Thank you, sir.
75% to 80% maximum. And
Okay.
if you go up to 100%, that time some images may be small. So that time it will not take. It will take, but some black screen will come on this in the results.
Okay, sir.
Then image array. So image is nothing but it is a combination of pixels, and pixels, they are nothing but in the form of row and columns. So if you check the image looks like this, right? Any image looks like this. So any image looks like this. Let's say if I write A, then if I zoom it, and you can see the image how it looks like. So this is how image looks like. So these are known as pixels. If we have a high dense picture or high quality picture, then if you increase the resolution, then it require more computation. So it should be selected according to the computing power available. So that's why free of cost you can go with a Google Colab, but Google free of cost, free service, Google is providing only some small amount of computation. What if beyond that you may get a license, or you may to get a GCP platform license, then only they will allow you high quality computation. But in my case, I have a computer that is having 32 GB of RAM. So there is no issues into that. So I have enough CPU and GPU. So that's why no need to go on cloud, Google Colab. That is the reason I'm using on my local machine. So 32 GB RAM I have. That is the reason. And this is a GPU. I have a 4 GPU. The good quality of GPU I have. That is the reason. It is better than the free of cost providing by the Google Colab.
Sir, please type in the chat box the configuration of the computer so that we can buy and we won't be depending on the Google Colab.
No. If you go to buy this much of configuration, it may cost more than 1 lakh in India. So especially you require, in my case, I can share my screen only.
Sir, means we have to, where we have to go if we are using PyCharm, we have to go to set that GPU.
Yes. By default, just you have to call through the Python code itself. It will select GPU.
Okay, so by default only GPU it will install. If we
Right, by
download the
default.
Python and install it,
Yes.
PyCharm.
If your laptop or machine have a GPU
Supports, no? Then,
driver, it require a GPU driver. If you have a
yes.
GPU driver, automatically request will be passed to the GPU.
Then
So
only. If you don't have that facility GPU, then it can't be done, no?
yes, it cannot be done. So
Yeah.
you can see somewhat code I process. It is request going to the GPU. And
Yes.
CPU is
Normally
almost,
laptops have a CPU only. GPU, then we have to buy separate laptop which is supporting that GPU.
pardon, can you repeat your question?
Sir, we have the CPU, no? Means if we want the GPU support, we have to take that laptop, buy that laptop which will support
Correct.
this.
And if you don't have, no problem. Existing computer itself will work, but it will take time.
Time, yeah. Thank you, sir.
So it's not a hard and fast rule that today itself you have to buy a new computer. No.
Yes, sir.
Existing computer can work, but it will take time in comparing to other computer.
Yes.
So I'm sharing a next method as well. So in this, what we are doing in this method. So the method name is which disease we are going to identify. So right now we have taken only two disease, only one disease. One is normal or COVID-19 infected. So like this, you can put multiple disease. As much as you want, you can put. And whatever image is processed, received, we need to convert into the array. And this image must be processed in the sequence of binaries, sequence of numbers. So that's why flattening array is needed. So NumPy will help us to process the each and every byte or bits. Is there any list available which images are disease or normal image? Yes, we have this. So if you go in the repository, where is the repository? Yes, this one. If you go in the repository and dataset.
One small doubt, sorry. If you can paste the code in one this, no?
It's
Because
already shared in the file already shared.
Where, sir?
In the same platform.
Where the PNG is there, no? So which file is there in that?
No, I shared. Okay, no problem. I'll share once again the same file.
Yes, sir. This Python file, sir, which you are
Yes,
showing.
Python file I'm talking about. The same file is already shared.
Yes, sir.
COVID-19 detection.
Okay, please share once again, sir. I missed out, sorry.
Okay, no problem. Please is sent. Please check.
Okay, sir. Thank you.
Thank you. So this is the list. of, so who is affected or who is not affected. So this list I have in the form of CSV, and all parameters are there. Now everything is fine, then it will return the array of image. If anything went wrong, it will return the something went wrong in the image. If out of the memory, or if image is very small, so in that case it will raise exception. Now coming to the recognizing disease. So one disease I have identified here, COVID-19. You can put multiple disease here. So process image. So whatever the binaries we have processed, so returning from the binaries, the same array objects we will pass here, and then it will check whether prediction is correct or not. If not, then it will check once again to predict. If any error, it will raise error. Otherwise, it will check once again. And then predictions means 0 or 1. So if something is 0, first array we are collecting whether person is affected or not. So predicted class. So predicted class, we have defined here class names. So we have two classes, either normal or COVID-19. And it will tell you whether confidence level, what is the percentage of COVID-19 effective. If something more than 60%, there is a chance, or more than 70%, there is a chance of affected image. So main program execution begins from here. And this is the function we have created on the top. This is the model creation. Model creation. And if model is okay, means model returns true, then it will load the image. So I have selected one image. So this is the first image I have selected, or I can select randomly. I can select many images. Any image I can select. And then it will search the same image on the required path. So this is the path we are providing. And we are passing this binary, image binary, to the recognized disease. And whatever the disease, it will return as a result. If anything goes wrong, it will return error. So let's try. So run this now. I have taken the first image, so it will check. It is getting trained. 1 DNN. This information is, if you see this type of message, that means it's just a warning message.
Sir, I have one query. Is there any criteria which you have applied for confidence score that beyond that
Yes,
number?
more than 60% or 70% based upon the accuracy. Less. See, we
You have
cannot.
written somewhere in the code that
Yes,
criteria?
yes. Threshold we have mentioned. Threshold we have mentioned here. On the top, we have mentioned the threshold.
Excuse me, sir.
Yes.
I am Shivdasan. Can we run this code in Google Colab so that there we have GPU facility?
Yes, sure.
Okay, sir. Okay, thank you.
So simply you can copy this code and you can go to Google Colab. Google Colab, and simply you can copy and paste. So it's loading now.
But when I am trying to run on Google Colab, it's showing the images file error, sir.
Yes. So you have to upload a file first. because
Okay.
you don't have a result. This file name you don't have. That is the reason.
Okay.
So I will upload some file. So this is a folder, right? So here I will upload some file. So this is a file. So I will upload some file. So I have a files located in this location. So PNG file I have into this. So PNG file, any file I will upload like this. So this is a file name, and I'll copy this name and I will put it here, this one place.
Sir, do we need to put the data set here again?
No,
Whichever you have
not
to
required.
put, then
Not
only one file will be sufficient to run this code.
Yes, because model is already trained. Just we are uploading our new file.
Sir,
And
but
see,
where we have loaded that model? Means this question came to my mind.
yes,
So
this one.
which point can you show we have loaded?
In this location, files. Can you see on the left hand side, files?
Yes, yes, sir. So we
Yes,
have
and
to
just click
first
on the
download.
upload. You can
Upload
upload
the.
an entire data set. All the images you can upload here.
Yeah, we have to upload, no? That means, and then we can
Yes,
run.
yes, you have to upload.
So can we upload image one by one, or we can upload all the images at a time?
Yeah, at a time you can upload. Select all and it will upload it at a time only.
Yeah.
So you can
Okay.
select like this. All
Or
images
we
can
can
be
make a
uploaded.
zip file and then we can do that. It is
Yes,
different.
both are. See this, I have uploaded all the files.
Yeah.
Sir, excuse me, sir.
Yes.
Sir, what do you mean by pre-trained? So that is no need to train again, or it is already been trained. Suppose I use your file. I'm new to this. That's why I'm having this doubt. Suppose I got your code, and I got the path also to some image that I want to check whether COVID positive or not. So in that case, this code has to be, will it work just like that, or is there any training required?
Training is required, because training is required according to you. Training is required.
Okay.
But not that much level of training. Small training is enough. Like if I give you, if you are going a showroom to buy a car, okay. So if I say in the car you don't have a mirror, or is something you don't have, that is not essential. So that you can buy later. So that is a part of modification, small modification. So you are just modifying the existing one by small modification.
Okay, sir.
And this model can be saved in one place as a single file as well. So same model can be reusable. I'll show you this.
Okay.
So same model is reusable again and again.
I want to add here on one of the point which has been just given. That is on your training question which you asked. Okay. So what happens that some of the models are already pre-trained. Pre-trained means what? They are able to provide some accuracy kind of result. But if you are adding some more features, in that case, you need to redefine those particular things and you need to train your model again. So that will give you better results basically. And training of model is what you can say, it's a continuous process. You cannot say that you have obtained the 100% accuracy. None of the model which is available has given the 100% accuracy, and it is next to impossible. It is not at all possible that any model will give you 100% accuracy. So this is the way you have to understand this concept.
Oh, okay, sir. So
Good afternoon, sir.
where this pre-trained model will be, sir? See, now I have opened this code. I have some few files to train by myself, and where will be the details of or the content of already pre-trained
Yes,
model?
we will be sharing. We will be
Okay,
sharing
sir.
this.
Okay, sir. Okay, sir. Thank you.
All right. So now this is the main code. But when we applied the only CNN with this, then how it behaves, let's check. This model, what is the accuracy level is you are getting in this case. So CNN we have applied. So one of the participant was asking the threshold, right? So uh, we are going to implement the threshold. So here I have taken the 32 by 32, but images can be small or bigger one. So as per your image size, with the image size, we can modify. And how many images you are going to consider in a single batch. Why batching is needed? Because right now I have only 100 images. What if I will be having thousands of images, millions of images? What about billions of images? That time it creates a problem. So that's why in a first shot, we are assuming the 64 images will be considered. If you want to make a small chunk, you can make. It's your choice. So this code is completely modifiable. This code as well I'm sharing with you, CNN image recognition. CNN image recognition. This code also I'm sharing with you. Okay, then epochs. So as I told you, these are pre-trained models. So if I go with 50 epochs, then I believe even my laptop also will take around 15 to 30 minutes minimum. Okay, and it may require, but still there is a chance of overfitting. There is a still chance of overfitting. So to avoid this, we need to set the threshold of epochs. And what is the learning rate? We need to set. Dear participants, if possible, please mute your mic.
So participants, please mute yourself.
Yeah, thank you. And how many classes you are going to identify? Like in a previous code, I have to taken two classes. Either it is normal or maybe COVID-19. But here I'm taking 10 classes. Disease 1, disease 2, disease 3, disease 4, disease 5. This is like that many diseases are possible. Okay, so we have a data set. This is a Cypher 10 data set. It's an already available data set. It will download it. And these numbers, I'm taking a 75% data set for training purpose or 25% for testing purpose. So we have selected the percentage. And out of that, how many classes we are willing to classify the model. So total number of 10 we are going to classify 10. And the training data set will shape level how much data set it is there. It will check each and every image will set. So let's run this so that you can understand better. So this model is getting started now. So data set is getting loaded. So now let's validate this. So first data set we have loaded around, it has collected of 50,000 records has been 50,000 record has been fetched, and this is taking this much of rows and columns, training levels. What is the percentage of data set we have selected for testing shape, labels, and test data shape. And finally, setting up the augmentation. So dear participant, what is augmentation in deep learning? Any idea?
Adding more data by rotation and reshaping the images, maybe scaling, rotation like that. Is it okay?
Yes, right.
To increase the
Yes, sir.
amount of data means medical, especially in medical field, the data is very less, no? So we can
Yes,
augment
that is
and
the
increase the images or data set. If build the
Basically, augmented is using for increasing the number of data sets.
yes,
Single image using number of times.
Fake data set. You can
Yes, sir.
say.
I have one doubt that load data you have just written for explanation, no? Means that model is only that sequential model which you have built. That small
Yes.
model that itself is the model in
Correct.
your program, no?
Yes, that's true.
Okay, and sir, that you were showing about the criteria, no? Threshold criteria.
Yes, I'm coming to that.
Okay, sir. Yeah.
So I would like to make a little more clarity about data augmentation. So data augmentation is a technique. Is artificially we are increasing the size of data set to reach on the certain conclusion or to generate a huge amount of data set so that we can find a certain conclusion. So why it is needed fake, why we are generating fake data set? Because if we have a less amount of data set, then there is a chance of overfitting. So overfitting, to avoid this problem, overfitting, we are using augmentation to avoid the overfitting problem. So but when you are generating fake data, there's a chance of including noise. So which makes performance very poor because this data is completely unseen, and the data augmentation exposes the model to wider range of scenario it may encounter the real world, enabling it to learn more robust generalizable patterns. Okay, so that is why it is needed. So to avoid underfitting or to avoid overfitting problem. That's very good. Let's proceed.
Sir, I'm unable to run the program, sir. Can you help me?
Yes, please share your screen. Quickly, please share your screen. Yes, please. Still, your screen is not visible. Yes, it's visible now.
Sir?
Yes. Yes. It seems your side internet is very poor because it seems your screen is stuck. I can see GitHub URL. No worries. If you stuck even after this presentation also we can discuss. We have we will provide a contact detail as well. You can contact to the organizer. They will forward your detail to us, or they will allow you to connect directly. Okay, so please.
Sir, Tarkeshwar sir, if you don't mind, can you post your details so that we can contact you afterwards?
Yes, definitely
If
we'll
you
do
don't
that.
mind.
Yeah,
Because your explanation is a very good, but the time constraint, it is not, it is a
yes,
very limited.
yes, time constraint. Yes, that is
Yeah,
why
yeah.
I'm also trying to.
Yeah, your explanation is awesome, sir, actually.
Thank you so much, sir.
Yes, participant actually, like, that 1.5 hour is not very much good for coding and other, but still we have made this, what you can say, sandwich kind of session in which we have told some theoretical concepts as well as coding. So
Making workshop, very good, nice session, sir. Please kindly help.
yeah, we will definitely help you. We'll share some more content to this chat window, as well as you can go through some research articles. So many things are available, and the organizer, sir, uh, like, that we had like, some little time. That is the reason these things are very much good for medical imaging and for your research also. But it takes time to understand each and everything. So it's time constant process.
Sorry for the disturbance. Avinash sir.
Yes,
Actually,
yes.
we have attended, some other FDPs. When compared to this FDP to other FDP, it is a more interesting and, enthusiastic. So we don't have time to interact. So that's what we are asking your
It
personal
happens.
contact, and
It
also,
happens. It happens. It happens. Let me tell you that right now you are attending a session with both an academic as well as a person from industry. So my intention was that I wanted to give the session, especially I requested my colleague Dr. Tarkishwar also, in order to provide some very interesting live examples on this concept. Okay. So as you understand that 1.5 hour session was not very much enough. So uh, definitely you can always, I have shared my number also, I shared my email ID also. You can always remain in touch. Everyone is invited to put their queries on either mail, WhatsApp, any like, any type. And I am very much proactive. I'll try to respond every participant.
Thank you, sir. Thank you.
thank you very much, sir, for your kind concern. Thank you, sir.
Thank you. Thank you.
Thank you. So now let's come back to the topic. So we are going to generate some augment fake data. So what type of fake data? From where we will get it? So let's check. So the image we have uploaded. So obviously, whenever we discuss about, let's see, one moment. I'll show you what exactly is happening in the background. I will show you. So this is my picture. Any picture I'll take. What is actually happening in the background? So see this. So this is the image, right? And I'll make a small one, little small, so that you can visualize correctly. So this is the one. Okay, so this is the image I have. So what we are trying to do, I can right here rotate and flip. See this. So sometimes doctor also not able to understand the properly. So usually doctor is using a technique to rotate the image. So like 90 degree, some certain amount of degree, they can rotate. But how computer will do? So this is the, so 15 degree. So we have selected. 15 degree we are trying to rotate the image. So rotation range is 15 degree. So maybe left or maybe right from the specific range to check whether we are on the right direction or not. Then width shifting. So what is the, so earlier we have selected 225 pixel, maybe 10% plus or maybe 10% minus, because sometime may be possible the valuable insights is already out of the range. So that is the reason we are trying to collect 10% plus or minus. So left width the 10% or height 10% we can increase. So this is how we are generating fake data and fake data from the original data, original image. And then image can flip. So image can be rotated, uh, flip as well. I'll show you how flip works. Flip. So flip this one, flip vertically. See this. This feature also available programmatically. Sometime you took an image, but it is available in the upside down or left to right. So this type of things may be possible. Zoom range, sometime image may not be clear. So 10% we are trying to zoom it. You can change this parameter. This code is already shared. So 10% I can zoom it and fill the mode. So whatever image, resulting image we found. So according to the strategy, we can fill the new pixel, created the transformation. Sometime may be possible. Some images was smaller than the specified range, but we are trying to increase the 10%. Obviously, you will get nothing. So fake pixels we are trying to refill from the nearest image so that we can approximately we can reach to the real image. So this is the place, and then train the data generated. So whatever data we have generated on, based on that we are going to train our model. So training, we are training our model, and then image data generator. This is a function used for batching purpose. No augmentation is already done. Why batching is needed? Because we have generated one image we have uploaded, but now we have at least 5 or 6 images, similar type of images. So that's why we require to process these images in a single batch. So batching is needed. Otherwise, your computer may run out of memory soon. So this is the explanation, written explanation is available in the comments. So please do not forget to read it. I'm trying to explain each and everything, but still maybe something I missed. So in such a case, you can go with the comments. Now, it require build a optimized CNN. Obviously, CNN, whatever we are getting may not be perform well. So in such a case, we need to optimize it. How to optimize? Because we have generated at least 5 images, and in those images we are trying to predict multiple results, and which is closer to the reality it will produce. So that's why optimization is needed.
Excuse me, sir.
Yes.
Sir, more 10 minutes only.
Oh, okay, sure. Okay, so now models, a sequential model we are generating, and we are adding layers, convolutional, two-dimensional, and once we have images, we are using activation function relu. Relu is blindly you can apply. Relu is always giving the best results, and batch can be normalized. So this is a sequence of max pooling, And finally, if something is goes beyond the normalization, then to regularize this, we need to increase the dropout. And then in the block third, so we have created this block 1, block 2, and block 3, and like that multiple blocks we can create. So right now we have only 3 layers, and whatever results we are getting, we have flattened. After flattening is done, we are getting one pre-trained model, and activation function is softmax. And finally, model we are going to prepare, we are passing the image, number of classes. So number of classes, how many we have taken? 10. And once it is up ready, then it will compile the model. So compilation is model. So this is the model architecture you can see on the bottom side. So this is a complete model diagram you can see. It's already visualized. And then it start training. So I have taken 50 epochs. You can take less as well according to your requirement. You can take 10. Usually you will reach on conclusion 10 to 15 is a suitable threshold for training. Sometime it may require 20, but not 50 is beyond its range. You should not go up to 50. So finally, it will print the summary and then early stopping, value loss, how much loss is coming. So you can see in the first epochs, we are getting around 30% accuracy. We are getting 30%. And then we are getting 51, 59, 64, 68, 70, 72, 74, 75, 76. And still this up to 77% we have reached the accuracy. And how many epochs? Only 12. Only 12 we have reached, but we have reached almost accurate one. So or when it will complete 20, or you will reach on this required results. Now reduce LO plateau and monitor the value loss factor, patient, and verbose 1. And finally start training. Once model is started training, so each and every epochs getting passed here. 50 epochs, and batch size is 24 at a time images. And finally it is evaluating. Once the training is completed, the model will train itself. It will evaluate itself, and it will give you the accuracy. So this is the accuracy we are getting. And finally, it will generate one comparison chart, plotting history, training history. So according to the history, the accuracy is increasing, loss is decreasing. So it will plot a chart. So this file is already shared with you. And good quality chart you will see in this high definition chart. Once all this thing is done, this model will save. So usually models are saved with the help with extension called H5. But if you want, you can use any extension name for this, as it is your choice. But usually in the industry, globally we are storing in the form of .h5. All right. So this is a model, and now coming back to this small theory. So now, typically what findings we have found in this. So this is the one of the most common earliest finding, GGO. GGO stands for ground glass optasis. So appears hazy. So sometimes it happens that image is not clear, and it sometimes feel like a glass, because X-ray image can reflect some lights. So that is the reason. Appear hazy area on the X-ray, almost like a blurry smudge. So these represent fluid. filling the small air in the lungs, but not the exact full of consolidation. So this findings can be subtle and this often more easily seen on the CT scan. So this is a problem, but it is telltale the sign on chest X-ray image. So as disease progresses, the inflammation becomes more severe. The ground glass opticis can evolve into the consolidations. So this is more dense and solid looking, while white area on the X-ray, which increases that the air sacs are completely filled with the fluid and inflammatory cell. The optics and consolidations of COVID-19 often have a characteristics distribution. They tend to be concentrated in the periphery outer edge of the lungs and in the lower lobes in the lungs. So this pattern is crucial, distinguishes feature from other type of pneumonia that might have more central distribution. So it was very common for disease to affect both lungs with opticis appearing on both sides of chest. So this is the diagram, how the uh, analysis is being performed. In the consolidation on the chest X-ray image is one of the clearest sign of active lung inflammation or infection. So it is essential what happens when the tiny air sacs in lungs called alveoli, so that are normally filled with airs becomes filled with something else like fluid, pus, blood, or inflammatory cell. So this fluid filled state makes the lungs tissues denser, and because X-ray cannot pass through this dense tissues as easily as they passes through the air. So the affected area appears as a solid opaque white area on the X-ray image. So in the context of COVID-19, this finding was particularly significant because it indicated the propagation from the more subtle ground glass opticis to more severe form of pneumonia, often requiring more intensive medical care. So the diagram you can understand, I will be sharing this slide with you just after this. So it is a hallmark finding in the early stage of viral pneumonia, including COVID-19. The phrases here to does not obscure underlying the bronchial or vascular masking. So think of as hazy, faint cloudiness in the lungs, and same symptoms you may see someone who smokes. So you can still see the outlines of the blood vessels. In the X-ray images, you can see clearly, and bronchial tubes through the hedge, which is what differentiate it from the more solid, opaque appearance in the consolidation. So the reason GGO were less commonly reported in the chest. This is our finding compared to CT scan is poorly method of resolution. So X-ray image, that's why it is much better. CT scan provides a much higher resolution across sectional view of lungs, make making it far more sensitive to these subtle has changed. One chest X-ray image, which is two-dimensional projection actually. So these findings can be easily missed or appear very faint. So in future, we have a plan to convert these type of images in 3D image so that we can reach on particular uh, findings or particular results conclusion. So however, the presence of was crucial earlier indicator of viral inflammation, often preceding the development of full-blown consolidation. So bilateral and peripheral abnormalities. So usually you will see the abnormalities. What type of abnormalities may create a distribution? So bilateral and peripheral distribution of abnormalities. Images may be blurry or many types of problem may come. But this, if you keep on training a model, we can avoid this problem as well. So the bilateral and peripheral distribution of abnormalities was one of the most consistent and defining the characteristics of COVID-19 pneumonia on imaging. So this pattern helped distinguish it from other type of pneumonia like bilateral or peripheral. So this means bilateral means disease affected both lungs, bilateral. So it was just a single an isolated patch of inflammation in one lung, but rather a more widespread process involving both sides of chest. So this describes the location of abnormalities, the ground glass opacity GGO and consolidation were typically found in outer region of lungs close to the chest wall rather than in the central area near the heart. What are the limitations? Obviously, we need to think about limitations. Lower sensitivity. So a chest X-ray image is simply not as sensitive as a CT scan, and the subtle has ground glass optics, the characteristics of early stage. So we are going to perform these type of tests on CT scan as well. Or the same code will be applicable on CT scan because more detail you will find on CT scan and often too fainted to be seen on X-ray. So leading to the false negative. So it was very common for the patient with the negative chest X-ray image have a significant finding on the follow-up CT scan. Lack of specificity, so we cannot find the exact point. So severity maybe affect around 10% if maybe sometime maybe 70%, but it can tell you 60%. If in case sometime it's a 70%, it can tell you 80%, 10% plus or minus we are considering into this. So if something we got a 50 or 60, so that means it is a type side of positive side, COVID positive or any disease positive. Okay, may not show early stage disease. Compute CT scans like a computed tomography known as CT scan is a better, giving better results. So organizer is not allowing me to go further. So we have to conclude the session. This slide I will share with you. This is our findings. Thank you, participants. These are the references of our paper we have used. If any questions, dear participant, you may ask me.
Sir, could you please put some light on any novel research topic on this medical imaging? Because nowadays there are many papers based on medical imaging, but sometimes they are confused. Everyone has done some work and they have got 90%, 99% accuracy. So is there any idea can you share with us so that we can work on that novel problems?
Yes, definitely. So nowadays, And nowadays, let me open the notepad. Yes. So nowadays, federated learning for privacy, preserving analysis. So this is the hot topic nowadays. You can work upon it. Another one, unsupervised and self-supervised learning. So you can work on this.
Is that
And
related
obviously,
to medical imaging, sir?
yes, yes. Generative AI for image synthesis and augmentation. You can use my mistake. Let me correct this spelling.
So in addition, I would like to tell dear all participants that when if you want to work on some medical imaging technique, so first of all, decide that on which kind of disease you want to pursue your techniques of applying the what you can say your uh, algorithms or your models. Okay, accordingly, if you are associated with any organization, university where you find that there are some healthcare related institutions or some medical college, if you are having, okay, then you can get yourself associated with one of the domain person from your respective institution itself, because the things which we have developed and we have shown to you is basically outcome that we have associated with many medical hospitals from where we can ready-madely obtain the different images. Okay, some of the images which has been taken from Google itself, but during our model training, we have taken many images, many from the real-time data sets from the medical colleges, which may be some private medical college or some government medical colleges both. So these techniques which has been shared with you and the current topics which has been shared with you by Dr. Tarkeshwar are the most appealing. So if you have your further interest in working all these things, then you can show your interest, okay, to us, and we will definitely guide you in future.
Thank you very much, sir, for this guidance and the positive support you have shown to
Sir,
us.
one more topic I want to add. Just a suggestion. I'm also doing my PhD, and there I could found like you can use also multimodal AI, which is very
Yes, that's true. Yes.
recent nowadays. So it can be done. And sir, I am also doing in research in TB diseases. So I would definitely require some guidance from you. So I will contact you, sir, later on.
Definitely, sure. We will
Okay,
feel good if you contact. Thank
okay,
you.
sir. Yeah, thank you so much, sir. You just share your email ID at the end session.
Yes, sure.
Okay, sir.
Avinash sir will share or a presenter will share.
Actually, participants have given the email ID as well as WhatsApp also. Most of the research which we have done, myself and Dr. Tarkesh, is a joint research. So you can always feel to contact me also. Okay, and we are in what you can say joint collaboration research, and definitely we will help. Okay. That thing has been already shared with you. Every in the
Okay,
chat,
thanks.
it has been.
Okay. Thank
Any
you,
other
sir.
questions, participants?
Any other queries? I think no. So in this session, here we'll wind up. It's a very good session and very interactive. And it's the first session that Dr. Tarkeshwar is showing the coding part. That's a hands-on, and many of the participants are practicing that one. and also asking the questions regarding this. And lastly, the participants are very much interested, so that they're asking the future aspects of the medical imaging research, all these things. And Dr. Tarkeshwar and Professor Sharma is also giving suggestions about the federated learning, unsupervised collegiate learning, and expression wide and multimodal learning. But most of the thing that most of the participants are asking about the how we know that this diagnostic tool is good for the diagnosis purposes. I want to mention that there is a start guideline. You may search that. I also share in chatbot that chat of the Zoom that there is a start guideline. So according to start guideline, if your method gives that much of the result, then whether it is good, very good, or excellent, that will support. Another thing is that most of the participants are asking about what is the current trends of the research. First, you go through the many recent research paper, then see what is the lacuna behind it or what is the limitations, all these things. Then you yourself search, and according to the availability of the data set, that is more important. And if you have the collaboration with as Sharma is suggested, that collaboration with the medical colleges, yeah, any type of the that medical college, private medical college or clinic, whatever it may be. So the most recently, I can suggest that there is women-related cancer. Go for the women-related cancer, means cervical cancer, that is ovarian cancer, breast cancer, like this. These are very right now means going exploring topic, and that is one is federated learning, and another is multimodal imaging. Multimodal imaging means there is you may fuse the features extracted by the deep learning that models you can use, and by doing this so you can fuse the features, that means deep features of the more than one or two models like that. Or multimodal means you can suppose ultrasound, and another one is CT scan or CT scan with X-ray, and again you can also doing fusing with that the clinical data sets of these things. Anyway, this is a very nice and interactive session. Thank you. Thank you very well. And I especially thanks to Professor Sharma that he makes this session very excellent. Thank you, sir. Thank you, Dr. Takeshwar.
Thank you. One of the participant asking question why we cannot use MRI images. Yes, sir. We have already trained our model on MRI images, but that data was proprietary. So for particular organization, we have received data set and we have worked only for them. So, but that data set we cannot use publicly, like in front of you. I cannot use that data because we have a certain constraint on that.
Yes.
Consent we require. So that's why I'm using here open data set and GitHub data set, public repository we are using. But same application will work as it is on CT image or MRI images. So no changes are required in the code. And further, if you require our support, we are with you.
Okay, I will share the email ID of the Professor Sharma. Okay, thank you. Thank you, sir. So in this way, so today all the systems is wind up, and tomorrow we'll again meet at 6 p.m. Thank you.
Thank you.
You may leave now.
Thank you, everyone.
Thank you, sir.
Recording stopped.